Welcome, everyone. I want to welcome you to this TTS Education Committee webinar in collaboration with the Transplant Journal on immune biomarkers for CMV infection. My name is Stefan Tullius. I'm the editor-in-chief for Transplantation. Outside of that responsibility, I'm the Joseph Murray Chair of Transplant Surgery here at Brigham and Women's Hospital. And I run the program here, the clinical program of transplant surgery, and an NIH-funded research lab over many years. I have the pleasure here to be today with Dr. Camille Kotton, who is going to share this session. Camille has been extremely active as a clinician. She is the clinical director of the Transplant and Immune-Compromised Host Infectious Disease Program at Mass General Hospital. She has spearheaded the guidelines for CMV and BK polymovirus in kidney transplantation conferences over the last year. There were four consensus conferences on CMV, 2008, 12, 17 and 24, that she shared. The most recent one that has just been highlighted and published in Transplantation. She is also very involved in the Transplantation Society, where she serves as secretary. She is the chair of the education committee, and most recently has taken on for the journal a role as education editor, where we in the journal will, moving forward, try to focus on educational aspects in the journal. So without further ado, I want to hand it over to Camille to guide us through this exciting session and to introduce the other participants. Thank you.
Thank you very much, Stefan. We have the joy today of having Dr. Bradley Gardiner with us speaking about his latest paper, Global Immune Biomarkers and Donor Serostatus Can Predict CMV Infection Within Seropositive Lung Transplant Recipients. We will then go into a question and answer period. Dr. Bradley Gardiner is an infectious disease physician and clinical researcher at Alfred Health, Monash University in Melbourne, Australia, and is passionate about the prevention, early diagnosis, and optimal treatment of infections in immunocompromised patients. He has finished his clinical training in 2013 and conducted research in this area, including a range of retrospective and prospective clinical trials. We are thrilled to have him with us today. As we're getting started, we encourage everyone to ask questions or make any comments through the webinar, through the Q&A window. We will try to answer all questions at the end during the Q&A period, and we really want this webinar to be interactive, so don't hesitate to paste your questions or comments. Brad, it's really wonderful to have you with us. Thanks for all your contributions to the community. You've really moved things forward a lot, and you were a terrific member of the most recent CMV guidelines as well. So go ahead.
Thanks very much, and it's really exciting to have this opportunity to share our work. Thanks very much for inviting me. So I'm going to talk today about immune biomarkers for predicting CMV infection in lung transplant recipients, a project that has been kind of ongoing for several years now, and this is the latest part of it. So, most people in the field of transplantation are very familiar with CMV. It's common, it's serious, it contributes to morbidity, mortality, and in lung transplant recipients, chronic lung allograft dysfunction, which is the most significant, life-limiting post-transplant sequelae. We do have all these great new tools available, highly effective antivirals, valganciclovir, neuroagents. The problem is these only work by transiently blocking DNA synthesis whilst patients are taking them. We've got tons of information outlined in the recent CMV guidelines document really well about how to prevent and manage CMV infection. We've learned a lot about this over the last couple of decades, and this has definitely reduced the incidence and severity of post-transplant CMV. However, it still occurs. Post-prophylaxis CMV is still a problem, and valganciclovir, which is still the workhorse of CMV prevention and treatment, is limited by adverse effects such as bone marrow suppression in up to a third of patients. And it would be great to have better ways to predict who's going to run into trouble with CMV and who's going to be low risk. And really, it comes down to this concept of we don't have a great way of measuring how immunosuppressed a patient is. This is the crucial thing in determining post-transplant infection and rejection risk. And there's this kind of simplistic concept of, too much immunosuppression, you're at high risk for infection, too little, you're at high risk for rejection. And that's served us really well for a long time. And so most post-transplant immunosuppression is guided by time post-transplant. It's often reactive to rejection or infection when it occurs. The main biomarkers are calcineurin mTOR inhibitor levels, and that's historically been about it. The problem is it's much more complicated than that. The immune system is incredibly complex, and we're learning more and more about it all the time. And so, some of these newer tests are an attempt to keep up with what's happening. So in terms of the immune monitoring assays, they kind of fall into a couple of categories. You've got these global sort of pathogen agnostic immune markers, and that includes things, as simple and as old-fashioned as immunoglobulin levels. The absolute lymphocyte count is definitely one that I know and love, and that's going to be a focus of the talk today. And then there's a few other sort of pathogen non-specific immune markers here. There's a whole array of CMV-specific immune monitoring assays. The QuantiFERON CMV has been a big focus of mine, but there's the ELISpot assays and the other platforms that are available elsewhere. And then there's heaps of exploratory biomarkers, and these have often been explored in small studies, single centers with varying outcomes, and it's kind of difficult to these are sort of in a really early stage of development. And the reality is probably to understand that full complexity of the immune system, we're going to need composite scores involving multiple biomarkers, clinical factors, and put together with complicated algorithms. So these two are going to be the focus of these have been the focus of my research up till now, and they're going to be the focus of what I'm going to talk about today. So this is our latest study. It's called Global Immune Biomarkers and Donor Serostatus Can Predict CMV Infection Within Seropositive Lung Transplant Patients. And this has just come out in Transplantation a couple of months ago. It's available online at present. And really, it focuses specifically on the R+ lung transplant patients. And the reasons for that are that we've been exploring the QuantiFERON CMV since about 2012 at our center. We trialed it and then introduced it to sort of attempt to guide primary prophylaxis duration. And the protocols we used were basically if a patient tested negative at 5 months, prophylaxis was extended to 11 months. And to cut a long story short, and this work's been published a couple of years ago, we sort of found that donor positive, recipient negative patients were highly unlikely to develop a positive QuantiFERON whilst receiving prophylaxis. And so the testing wasn't really very useful in that group. And that led us to focus in this study on the recipient positives, who previously were mostly also QuantiFERON positive. And we noticed that many developed CMV despite this result. And so the aim of this study was to explore the two other immune biomarkers in this group, the absolute lymphocyte count and the mitogen component of the QuantiFERON CMV assay. So just as a quick reminder, the QuantiFERON CMV assay is similar to the QuantiFERON TB. There's 3 tubes. There's a control tube, a CMV tube, and a mitogen tube. And basically, the patient's blood is put into these tubes. It's stimulated, incubated, and interferon gamma is measured in response to either CMV antigens or this, non-specific mitogen immune stimulant. And it's this tube that we looked at for this study. So we took all of our recipient positive lung transplant patients who had QuantiFERON CMV testing done at 5 months post-transplant. And the outcome we used was any CMV infection over 150 IU per mil in either the blood and or the BAL, the bronchoalveolar lavage fluid. And this is a low threshold, and part of the reasons for that was because a lot of viremia was identified at a lower level, and patients were treated promptly, preventing progression to more significant disease. So to capture all CMV events, we had to use this kind of low threshold. The role of CMV in the BAL is in lung transplant recipients is a little bit controversial. At our center, we screen and treat patients who develop CMV in their blood because we think it's associated with CLAD. That's not universal in all centers worldwide. So our cohort was 204 recipient positive lung transplant patients. 60% of them also had a CMV positive donor. And overall, the median valganciclovir duration was just over 5 months, with about a quarter of the cohort receiving extended prophylaxis to typically around 11 months. 75% of the patients were quantiferon CMV positive, 15% negative, and 10% indeterminate. And overall, 54% by that definition developed CMV infection. You can see that the median peak viral loads in blood were around 630 and in BAL were around 3,850. 20% developed CMV viremia, whereas up to 50% developed CMV reactivation in the BAL. Because of the importance of valganciclovir prophylaxis in determining CMV risk, we adjusted all our analyses for the duration of prophylaxis. So our first finding was that donor seropositive patients who received an organ from a seropositive donor were almost twice as likely to develop CMV infection, 66% versus 38%. And this was striking to us. It has been reported elsewhere, but we thought this was really important and potentially clinically informative. So patients who went on to develop CMV infection did have lower absolute lymphocyte counts, 1.1 versus 1.4, and lower mitogen values, 2.8 versus 4.6, at that 5-month time point. And both of those were statistically significant. We use receiver operating characteristic curve to calculate optimal cutoffs, and the lymphocyte count cutoff, I kid you not, came out at 1.0, which is a great cutoff. The sensitivities and specificities are listed there, and they're not perfect, as you can see. It's 60 to 70% mostly. When stratifying by patients for their CMV outcomes by those cutoffs, you can see that patients who had a lymphocyte count of below 1 were about twice as likely to have CMV unadjusted, and patients who had a mitogen value of less than 3.6 were about 1.5 times more likely to develop CMV infection. These are the adjusted hazard ratios here for adjusting for serostatus and antiviral prophylaxis duration. You can see for every 1,000 cells per microliter decrease in the ALC, the risk of CMV increased by 1.6 fold. Similarly, for every 1 unit decrease in the mitogen value, the hazard ratio was about 1.1. And the effective donor serostatus was independent of prophylaxis with a hazard ratio of 2.3. So the next thing we wanted to do was look at, in many things, 2 is better than 1, right? In life, in medicine. To measure the model performance, we've used the C statistic, which is basically similar to the area under the receiving operating characteristic curve. And you can see here that 50% is equivalent of a coin toss and 100% is a perfect test. So donor serostatus and ALC alone were both around 63%. Mitogen was about 60%. Combining lymphocyte count with serostatus pushes it up to about 68%. And mitogen and serostatus is 66%. But to our surprise, actually adding mitogen to the lymphocyte count and serostatus didn't further improve the model fit, the predictive utility beyond beyond just Serostatus and ALC alone. This was a bit surprising. There was a weak but statistically significant correlation between ALC and mitogen values, but in our analyses there was no evidence of collinearity between these variables. So how could you maybe apply this clinically? Well, what we've sort of proposed here is that if you combine together donor serostatus and absolute lymphocyte count, you can restratify patients into these sort of low, moderate, and high risk groups. For example, if a patient had a seronegative donor and a lymphocyte count of above 1 at 5 months post-transplant, their their subsequent CMV risk is about 1 in 4. However, patients who were donor positive and lymphopenic were 75% of those went on to develop CMV infection. And these simple factors could be applied at this early time point post-transplant to inform the subsequent CMV risk. And although there's a similar trend with the mitogen values, similar findings really, given the added costs and complexity of doing this test and the fact that there wasn't really additional predictive utility beyond the lymphocyte count alone, it's sort of hard to go past the left-hand side here. And so I do wonder, rather than there's a real strength to protocolized management of transplant recipients, but it does mean that all patients are treated the same, and it doesn't really allow for a nuanced individualization of risk. Whereas this whole concept of personalized medicine, where you'd use these immune biomarkers potentially like Serostatus and ALC to help guide different decisions for different patients, things like these could inform like antiviral prophylaxis duration. You could maybe look at stopping prophylaxis earlier in patients who've got no lymphopenia and negative donors, or extending prophylaxis for longer in higher risk individuals. You could use it to inform frequency of virological monitoring, perhaps even immunosuppression management, although we've got some ways to go with that. So overall, these immune monitoring assays have improved our understanding of post-transplant immunity, infection risk, and helping to measure the net state of immunosuppression. The lymphocyte count is simple, inexpensive, easily measurable, reliable, and consistently associated with not just CMV, but also other infections post-transplant. We don't know yet how to optimally integrate these into clinical practice, and we do need larger, well-designed, carefully thought out studies to further evaluate them. Thanks very much.
Wonderful. Thanks very much, Brad, for leading us through that excellent work. It's so interesting. It really seems like if you use both mitogen and ALC together, that should be more predictive. What are your thoughts around that, or what type of work might you be doing to, look into that further?
We were really surprised that it didn't add more predictive value, and that there, in the absence of more predictive value, well, the obvious explanation is that they're collinear with each other. We didn't really find evidence of that. We did. A group from China actually wrote a letter to the editor, which we've just responded to, and it's going to come out shortly. Sort of wondering if there's maybe more complex nonlinear relationships between these variables, and they sort of proposed that we could look at that maybe with AI machine learning models to sort of try and understand that. We haven't done that. There are some sort of that. While this is an exciting, appealing approach, there are some limitations you need to be careful of. And so we don't, at the end of the day, we don't really understand why there wasn't extra predictive value, but we have done the analysis in multiple different ways, and haven't really found that it adds more beyond just the lymphocyte count alone, which is a great test. And for a new test to be implemented, it would really have to increase the value. You'd have to be getting a lot of value out of that, given the costs and laboratory work needed to bring it in.
Related to that, Jen Lee has a question in the chat. Jen Lee is the co-chair with me on the TTS Education Committee. She says, thanks for the interesting talk. Could the test performance of quantiferon and mitogen be affected by the lymphocyte count itself, e.g. false negative after antithymocyte globulin, etc.? I was surprised there was no collinearity. It's like,
Yes. So thanks, Jen. Thanks for the question. So we did see, like, if you plot out the, the lymphocyte count versus the mitogen, there is a little bit of a correlation. It's not strong. It was about 0.25. It was statistically significant. One of the other limiting factors of the mitogen value is it's not really established as a diagnostic test, right? It's a within tube control. That's its idea, to sort of detect lymphocyte responses. So one of the issues is that the values are actually capped at around 10, and we had a lot of values clustered at that higher end, and so perhaps if perhaps that there's more information above 10, and perhaps if you knew the actual value, then results may be different. But yeah, you've got to both have an adequate number of lymphocytes and adequate function of each lymphocyte. And I think both of those things should be important. Yeah.
right. Very, yeah, very helpful and interesting to think about. I know a lot of people have kind of broken down quantiferon and looked at thresholds and all kinds of things, trying to get it to be as optimal a tool as possible. There's another question in the chat. So this is from Nadeem Baruni. Thanks so much, Dr. Gardner, for the presentation. Can I ask how readily available the CMV-specific biomarker testing is available, and are there any plans to test the other markers?
Yep. So there are a number of different CMV-specific biomarkers available worldwide. There's the quantiferon platform, which is probably one of the most common, and it's got a lot of advantages. It's like in tube, it's simple, it's easily implementable in a diagnostic lab. There's the ELISpot assays, which have been more popular in Europe. We don't have access to those in Australia. In the US, from what I understand, there's only one assay, which is the ViraCore assay, which is different to the others and not that well studied yet, although I think there is some emerging data on that assay. So this is one of the challenges, and actually we talked about this a lot at the guidelines. Each study has used one assay, the big trials, mostly done in Europe, and can they be extrapolated, I guess, there was a lot of discussion around, can you apply the findings to one population using one test to the same population in a different place using a different test? And we think probably you can, the concept's translatable, but the data isn't really there. For our next steps, if we, next time we start recruiting patients prospectively, we do plan to collect, multiple samples of multiple different biomarkers concurrently, to sort of try and help answer some of these questions. Yeah.
Yeah, that sounds good. I think the data have been sort of slow to accumulate for all of those tests, as you outlined, T-spot CMV, quantiferon CMV, and then the ViraCore assay. And it looks as though they're a little more available in multiple different regions, but it's often region specific as far as availability. So that's been a restriction. I will say that in exciting news in the CMV guidelines, for the very first time, this is the 4th version, we finally have a recommendation that cell-mediated immunity testing can be used to predict the optimal duration of prophylaxis in CMV seropositive kidney transplant recipients. So that was your group that worked so hard on that. And so we finally do have a recommendation for clinical use, and I'm hoping that might allow for more widespread availability of these diagnostic assays. But that to be determined, I think.
Yep, and yeah, that was one of the biggest changes I think in this edition of the guidelines, that the immune monitoring section's been totally rewritten. Yeah, I was lucky enough to be part of that group, and it was really exciting. It was led by Ariel Manuel, and it's actually the Europeans that have mostly done the recipient positive kidney studies, and they're excellent studies, and they do show that it's a reasonable option in kidney recipients to employ this CMV immune biomarker guided approach. It can save you about, there's one study that shows it saves about a month or two of prophylaxis with a similar CMV risk. And so it's another option that's out there now, becoming more popular.
For the guidelines, one of the more disappointing things was that, so we do recommend it for seropositive kidney transplant recipients who already have a fairly low rate of developing CMV. Sort of one of the sadder conclusions is that right now, this type of testing is not useful or recommended in the high-risk CMV donor seropositive recipients seronegative population. So that was, that's the very high risk. That's where we see the significant burden of CMV. That's where we see resistant refractory disease. So I think it's important to highlight that aspect of the guidelines. So recommended in seropositive kidneys, but not recommended in any recipients who are D plus or minus. I do get a lot of emails, Brad, about kind of willy-nilly use of the cell-mediated immunity assays outside of clinical trials, and just people frustrated with CMV, so just sending the testing. What do you think about that from a stewardship and cost perspective and clinical utility?
I admit I've been guilty of that on occasion. In the most complicated cases, you kind of do it. I got a couple of resistant refractory cases where I've tested it to try and get a sense, and I've seen some patients who just never develop a response, even after terrible CMV infection, and then others who have developed a response finally, and I've used that to help inform some decision making around stopping or antivirals, or it's not it's not perfect, right? Yeah, it's not perfect, and just because someone has a positive test doesn't mean they can't get CMV infection. That I've definitely noticed. But it is another piece of information. It's another data point. It's another tool that we have in the kit, and it's finding its place increasingly. And I think probably the lung recipients are a bit unique. They're much more immunosuppressed, and there's this whole BAL issue, and so I guess uptake's been slower in that group, and perhaps it'll find its feet in the kidney realm initially.
I think it's wonderful to have this discussion. I think it's so important to really discuss and understand the details of diagnostics and treatments of CMV. And the journal has been fortunate to have both the CMV guidelines published, having your work published, having this lively conversation, both in the journal, you mentioned the discussion that we have, and with the participants of this webinar. There's another question here by Jen Lee, who is asking, what other tests or assays are in the pipeline on the horizon that you might be excited about in this area?
Well, I mean, we've looked at the quantiferon monitor, which is another non-specific immune biomarker. That's one that's out there getting explored. TTV, torctinovirus, is this non-pathogenic anellovirus, which seems to replicate at higher levels with immunosuppression, with increased immunosuppression, and that's certainly getting a lot of attention out there. And there's a number of trials underway, mainly in Austria, that are looking at that. Then they're probably the front runners, I guess, in this kind of area, plus all of the CMV specific ones. And I guess the other sort of area for, research in the next 5 years, would be maybe using like AI models to put all this data together in an interpretable way. And actually, I listened to the Alex Loopy's podcast a couple of episodes ago, and was really fascinated to see what those guys are doing. And I think, given the complexity of everything that's going on, look, simple tools are helpful, right? Because you can use them clinically to guide simple decision making, but to really understand and really individualize and risk predict, you probably are going to need multiple tests crunched with a complex AI model ultimately.
I think, yeah, exciting opportunities moving forward.
Yeah. Brad, what do you think, if you could design the perfect trial moving forward, what would that look like? I do understand the complexities, and especially around lung transplant, but if you had your dream, what would that look like?
Yeah, I've wondered if maybe we're ready for a lymphocyte guided duration of primary prophylaxis in the R plus group. But actually, probably before a trial, we might need more observation. Well, there's actually a growing amount of observational data out there already, right? Actually, in the guidelines, we summarized. I had the honor of writing the lymphopenia and global immune biomarker paragraph, and we put in a supplementary table that summarizes about 14 or 15 observational studies, which is described an association between low lymphocyte counts and CMV risk, and yeah, I wonder if maybe there's the opportunity to randomize people based on their lymphocyte counts and look at stopping prophylaxis once lymphocyte counts are above 1 or whatever value we kind of choose. Similar to what's been done with the quantiferon guided prophylaxis studies. If we're going to go to all that time and effort, you would probably want to, like I said before, collect multiple different tests and kind of try and help understand which ones are the most useful, and are 3 better than 2 or 2 better than 1.
Yeah. There's been some interesting work in the stem cell transplant realm where they now have pretty good predictive models for the overall risk of CMV and who would best benefit by letermovir prophylaxis. And it seems like we aren't quite there yet in the organ transplant realm, but it does seem like a trials like that could be quite interesting, and could be really contributory. On a very practical note, your work that you did when you were at Tufts with the absolute lymphocyte count predicting the risk of recurrent CMV infection has been incredibly helpful for me, and for those of us using electronic medical records. I actually have a dot phrase that collects all the lymphocyte counts, so I can readily predict, just with like a few keystrokes, I can see all the past 20 lymphocyte counts and predict the overall risk of developing subsequent CMV. So these things are pretty readily implementable into electronic medical records. People can message me if they want more information on that.
It's real, like when you're out there looking at your consult patients, and look, it's hard in ID because we only see the worst ones, right? But I pay attention to what the lymphocyte counts are, and in the people where they're low, they seem to be the ones who really struggle with CMV and all sorts of other infections.
Yeah.
And once you see it, you can't unsee it.
And maybe this is a real issue because sometimes they're just on, say, 2-agent immunosuppression, or their immunosuppression's been reduced, but their absolute lymphocyte count is still really low. And that's where, many of the transplant providers will say, oh, their immunosuppression's low enough. And you're thinking, well, their absolute lymphocyte count is still so low. And I think that's that high risk population that we don't really know what to do with. And we really just need better markers for what Dr. Robert Rubin at Mass General decades ago would call the net state of immunosuppression, so we could optimally manage these folks. Great. Well, thank you so much for all of this. Really wonderful, wonderful work. And I know that you have lots of additional work underway, and we are really excited to see that work. Thanks for all your contributions to the guidelines, the CMV community, the transplant ID community. You certainly do a great job representing Australia, and not necessarily a huge population, but a very vigorous contributor to all of transplant medicine. And we do look forward to having the TTS meeting there next year in Sydney. And I'm sure you will be featured there quite prominently. So if people want to meet up with you, that would be an opportunity, I imagine.
Yeah, no, very much looking forward to it. And yeah, we do the best we can, you know. But no, thanks very much for the support and the opportunity to chat today.
No, that was great. I think it's great to have this discussion, as a webinar, as a live discussion, in addition to the information that we provide through the journal. And I think it's going to be very exciting to see what individualization will be able to provide us in regard to opportunities and challenges for CMV detection and treatment.
Great.
Yep, for sure. Thanks.
Thanks a lot, everybody.
Thank you. Bye.
Okay, bye.